So great to see you all. I'm super excited about this. I appreciate you all being here, and I'm looking forward to getting to talk with hopefully with many of you as we go on throughout the day. I want to welcome you to the second annual OHSU Health Literacy Symposium. My name is Cliff Coleman. I have the distinct privilege of getting to be the chair of the planning committee for today and the chair of the OHSU Health Literacy Work Group. And I'm just going to do a little bit of kind of housekeeping stuff with us before we introduce our first speaker. Before I get into that, I want to just thank a few people. If this will work. Yeah, there we go. So that you can see there's our planning committee there. If you're a member of the planning committee, would you mind just standing up so we can just thank you? Awesome. Tons of work went into this, so I really appreciate you all. I want to thank our co-sponsors for today. Megan Pugmire, who's VP of Brand Experience Marketing and Communication in her office, for your generous support of our symposium today, and the OHSU Center for Ethics in Healthcare, and our immediate past interim director, Katie Stowers, and our current and new medical director, or new director, Fabrice Jaturnde, which I don't know if you're in the back there. Thank you for your support. We really appreciate it. We couldn't do this without you. Just a little bit of housekeeping before we introduce our keynote speaker here. You have the schedule for this afternoon in your packet. And I should also thank our provost, Marie Chisholm Burns, for support and especially for your generous support in helping learners show up here and giving scholarships for learners to be present today. So we really appreciate that. Thank you. So you have the program there. Please, you've all signed up for breakout sessions. We have limited space, so please stick with the rooms that you've signed up with. Otherwise, we're going to have trouble with seating. We're not supposed to be eating or drinking in this room, so if you haven't finished your lunch, if you could just hang on to it, it's okay to eat in the other room, so you can take the food and drink out there. And bathrooms are out into the foyer, down the stairs, or down the elevator, and on a lower level here. In this room, this will be one of the breakout rooms, and in this room, the sessions are going to be recorded even in between sessions. So if you're in, make sure you're not taking a patient call or any kind of thing like that in this room. The other rooms are not going to be recording. And then lastly, at the end, we'll have an evaluation. There's a QR code in your packet, I believe, and I'll have that up on the screen here at the end, and just please fill out your evaluations. So now, it's my distinct pleasure to introduce Megan Pugmire, who's our VP for Brand Experience Marketing and Communication. Megan is a longtime health literacy champion and friend, and she's been passionate about helping us see healthcare through the eyes of patients and families, and helping us recognize what that journey looks like and feels like as a person coming to OHSU. It's been very instrumental in the efforts that our health literacy work group have taken on in helping OHSU to become a health literate organization. And so let me bring Megan up to help us introduce our first speaker, and I'll come on up. Thank you.
Okay, great. Good afternoon, everybody. It's great to be here with you this afternoon, and it's really heartening to see everyone focused on health literacy and our roles in innovation across our missions at OHSU and beyond. I know we have some folks who are visiting us from outside the organization this year, which is really exciting. For those of you who don't know me, even though my full purview right now is on brand experience, marketing, and communications, my background is in graphic design and as a creative director. And my husband is also a creative director and a director photographer, and this means that probably anyone else in this room would be better in an emergency than we are. But besides that, we spend a lot of time together thinking about what it means to see and seeing, and about art and narrative and bringing other perspectives to life. So we have a framed quote in our house by the French film director Robert Bresson that says, "Make visible what without you might perhaps never have been seen." And for me, this vital revealing, this visualization of the story that is another human being is not just the purview of the artist, but also of all of us as empathic human beings who are working toward greater equity and justice. And part of the beauty of all of us being gathered here today, focused on health literacy, on clarity and communication in a system, is that it means we necessarily must consider the experience of others who are not us and what they may need. In a fractured and chaotic world, this seeing, this making visible of the layers of living couldn't be more important. And I'm looking forward to today, not just because of the practical theories and tools that we'll learn, but because of the community that's created when we come together to solve complicated problems in a complex environment, and the creativity that's generated when we start to peel away the layers of the everyday not seeing we inevitably accrue. So to that end, I'm thrilled to introduce one of my favorite people here at OHSU, who imbues his work with curiosity and boundless energy, and who continuously asks us to look deeper, build stronger bonds, and do the necessary work of making visible. Dr. Don Speight is a professor of surgery at Oregon Health and Science University and a staff physician in the Operative Care Division at the Portland VA Medical Center. His clinical interests include laparoscopic and robotic foregut surgery, including bariatrics. In January of 2023, Dr. Speight was named the inaugural Vice President of Health Equity for OHSU Health. And in this role, he leads a portfolio of patient-centered operations designed to ensure alignment of system experience with OHSU's mission and values. Dr. Speight's responsibilities in this role have grown as OHSU has sought to ensure effective and equitable policies, processes, and operations for all people. He currently oversees the OHSU Health Equity Organization, Language Services, Patient Experience, Patient Relations, the Office of Visitors and Volunteers, Concierge Services, Cascade Life Alliance, and the Life Flight Network. Please join me in welcoming Dr. Speight to the stage.
Good afternoon, everybody. I'm going to see if I can swap this thing out real quick to get my slides up, so bear with me 1 second. This is the first test. Let's see. All right, got something up now. The second test is whether my slides will advance, but I think they will. So first of all, thank you, Megan, as you're also one of my favorite people. I'm always inspired by the quotes that you deliver. Last time we met, I think you were talking about really the difference between a house and a home and understanding the things that go into it. And so I'm going to have to write down that quote that you said so I can look into it and unpack it a little bit. I'm really happy to be here. I look through the audience and I see many people that I know are passionate about this work that I look at as co-conspirators in this struggle for health equity, for health literacy, and for all of the work ahead. I want to thank Dr. Coleman and your collaborators at the Center for Health Ethics for inviting me and for putting on this symposium. And thank you to the planning committee because this is really important work. So I'm looking forward to a robust program today, and I'm hoping to spend as much time as I can here with you, but I'll have to dip out earlier, so I'm trying to absorb it fast. So Cliff, thanks to you, I can't walk past a whiteboard in a patient's room oblivious to the medical foreign language that I speak as a surgeon. And it's one of those things that once you see it, you can't unsee it. I remember back in 2020, I think it was, when Dr. Coleman gave one of our health equity symposia, and he showed me a slide that looked something like this, and I looked and I was like, yeah, that's what we, it's on the patient rooms, and through that process, I really learned really about the blaring omission of humanity that often occurs in the clinical spaces in which we're trying to deliver care to patients in their most vulnerable need. And sadly, it shows up in many ways beyond what's seen here. And I'm honored today to be here in solidarity with the health literacy, all the folks in health literacy in the work that you're leading. So I'm going to ask a question. How many folks, not the clinical people, so Dr. Coleman, you can't do it, and any of the non-clinical people, how many people have any idea what this says? I see a couple. Throw it out there. What is the first half? So what is NPO except for meds?
No oral intake, no food or drink.
Yeah. And what about the second? Anybody know the second? Non-clinical person. Anybody know what the second part is? Banning.
I think that's type of that. So maybe I'm cheating, but I don't know. Maybe it's not.
In the spirit of nicety, I'll say close, but no. So this is something that you might see that's put on outside the patient's room on their whiteboard to help remind them. I don't know why, because nobody knows what it is, but also help the team be reminded of what is supposed to be happening. So NPO except for meds, nothing per oral, nothing by mouth. UUOB is up out of bed. TID is 3 times a day. So close, but not great. So up out of bed, TID. And if you were a patient, what would this mean to you? Nothing. Imagine if you were the patient's family member who's trying to be as helpful as possible. What does this mean to you? Nothing. And thankfully, due to the work of many in this auditorium, these types of whiteboard notes are much less common today. I think many of us as clinicians, when we see these types of things, we now erase it and write something that is maybe something a little bit more direct. I think it's important for us to all take that opportunity to really provide for the patients in their most time of need. But that said, there's a lot of other areas where there's still a lot of work to be done. Certainly as a surgeon, I can guarantee that when I walk into my patient's room right before we're about to start surgery and I say, hey, what are we doing today? I can guarantee you that they don't say, oh, we're going to do a robotic-assisted transabdominal preperitoneal inguinal hernia repair with mesh. I guarantee. Usually what it is kind of like, you're going to like do some stuff over here and you're going to move it around and I'm like, yeah, that's kind of it. Yeah. But this is what it says on the consent. This is what they signed. This is what they signed up for, and that's a huge problem, and it's certainly a mouthful. So I want to ground us today in the idea that we're not just talking about words and pamphlets and readability scores. What we're talking really about is power. We're talking about who has access to information, who gets to understand the system, who gets left behind by the very institutions that we build and design to heal people. Because when somebody doesn't understand their care plan, they lose the power to make truly informed decisions. And this is a form of inequity, and it must be treated with the same urgency as we treat the problems with access and quality and safety. Because there is no equity without health literacy, and there's certainly no health literacy without confronting systemic inequity. The reality is that in Oregon, 1 in 5 people struggle with basic health information. Patients from zip codes east of 82nd Avenue, so our deep east side, many of whom face economic and socioeconomic language barriers and other things, return to our emergency department at higher rates because of follow-up plans that were not explained in ways that are aligned with their lived experience in the way that they move through the world. Patients reading at or below the 8th grade level struggle with our current MyChart instructions. And that's if you speak English. Imagine if you're reading at that level in Spanish. And although we're trying to build systems to accommodate that, these are problems. And certainly we just talked about the consent forms in our discharge summaries that are written in ways that assume health literacy and not at all real life literacy. So despite the internal and external headwinds that we're seeing, we have to keep striving to advance health equity for all people. And that includes you, everybody in this room. We oftentimes sort of pigeonhole health equity to think about race and ethnicity and religion, but it is socioeconomic, it is education, it is disability, it is age, it is everything. And so your uniqueness is represented within the work that the Health Equity Organization embodies. And this is the work. And we must ensure that effective and equitable policies, processes, and operations are part of our daily life. And we have to build truly inclusive clinical experiences for the patients that we care for. And that journey begins with a health literate organization. And so I'm really aligned with work that we are hearing today, and I'm proud to be part of this family with you. That really is one of the most impactful endeavors that we can do and undertake on behalf of Oregonians. Because if patients can't understand what we're saying, they can't partner in their own health care. If medical decisions are made without full comprehension, what happened? Sorry. Let me see. Gave me a. Oh, there we go. If medical decisions are made without full comprehension, consent can't be ethical. And when language is a barrier, care is neither safe nor patient-centered. And when we communicate clearly, we do more than deliver information. We return power back to the patients and back to the communities that we're taking care of. So we say that people deserve to walk through our doors at OHSU and feel that they matter. Health literacy gives people more than information. It gives them dignity. It allows them not just to receive care, but to own their own health, which is so critical in today. And so we're sitting in here in this auditorium over the course of our time here today, really learning the nuts and bolts and the science. This is an action-oriented symposia, and I think it's going to be excellent for us to develop this practice, but we have to remember that at its root, it's about people. It's about a single mother who's trying to understand what she's going to do with her discharge instructions for her small child after the ED visit at 2 a.m. It's about the patient with limited English proficiency that comes in and doesn't have an interpreter, not because they don't want one, but because one is not available. It's about people like my father, who's on dialysis, and he receives his after-visit summaries with his nephrologist, and he asks me, why don't they work to get me off of dialysis, without any understanding of the numbers that are in front of him and the fact that they don't tell that story. And it's certainly about people like grandparents that might be in this room that are stopping their insulin because they're worried about the complex instructions that they're provided about how to take that insulin and how to do that in a way that's safe. And these are not literacy problems per se, these are systems problems. These are things that we have to navigate. And the work is ongoing to transform patient experience and health equity on multiple different fronts. And that includes the critical impact assessments that we have to use to drive our strategic decisions. It has to do with the community-driven mobile outreach efforts that we're doing to meet patients where they are. It has to do with greater coordination across our care teams to ensure that people know that we actually talk to each other. It includes the grievance responses and the ability to process those quickly and in the compliance with the patient regulations that center humanness and human rights. And it certainly includes the deeper alignment of equity-centered measures of quality that we know are so important. And we can't do any of this well without health literacy. It is part of the work. That's why I said they are the same. If people can't understand us, they can't trust us. And if they can't trust us, they're never going to choose us. And so health literacy is more than just a moral imperative. It's strategically essential to the work that we're doing as an academic health center that serves all Oregonians. And health literacy becomes equity when we move from intention to design. And what that means is that we can't just assume that people have different levels of health literacy. We have to assume that everybody needs access to health literacy. We have to expand our interpreter access. We certainly will hear a lot today about teaching back and appropriate strategies that are data-driven, shown to improve compliance. And we have to have culturally rooted education that goes as part of that, that's designed with the community, not just for the community as we see that they need it. And we have to think about the accessibility of our communication platforms. We have to build clinical training programs that really allow workforce development. And we need to audit this activity and audit equity in the communication in the same way that we audit safety. It's critical. And finally, we need to center trust building through design, not as charity, but really as a means of accountability to ensure that our health system is truly capable of delivering the highest quality, safest, most effective and efficient care for everyone that comes to our door. And so in closing, I would encourage you all to lean in today. This is really powerful work, and my hope is that this summit not only deepens our understanding, but also moves towards action, which is the intent here today. Let today be the moment that we stop treating communication as a soft skill and really start treating it as a clinical skill a safety requirement for the care that we deliver, and certainly as part of that right of all human beings, which is healthcare. So with that, I'll give you back, and thank you for inviting me today. And I will plug this back in and make it easier. Hopefully that works. Yeah, perfect. Thanks.
All right. Let's see, I don't think, okay. Thank you both. That was great. I'm already so excited to see what's going to come next. Now I have the privilege of getting to introduce our keynote speaker. And I'm going to read here because there's so many major accomplishments that I'm not going to be able to keep track of all of them. Dr. Marianne Abrams is, in addition to being a longtime friend and colleague in the health literacy world, is an assistant professor at the Ohio State University College of Medicine, Department of Pediatrics, and is a primary care pediatrician at Nationwide Children's Hospital in Columbus, Ohio. Connecting theory with practice, she leads the development of tools, resources, and trainings to advance organizational health literacy, which she's going to talk to us about today. And she publishes on health literacy and interventions, as well as curricula. Dr. Abrams is a national leader in health literacy, illustrating how it is integral to the dimensions of health and healthcare, and is fundamental to things like quality, safety, equity, and patient, family, and client-centered care and services. She has led very large health literacy learning collaboratives and quality initiatives focused on implementing and sustaining health literacy-related interventions in real-world clinical settings. She's co-authored toolkits and academic works, including the Always Use Teach Back Toolkit, published in 2024, and as well as Building Health Literate Organizations, a guidebook to achieving organizational change, second edition that came out also in 2024. She literally wrote the book on this topic, right? And as well, I would venture to say that Dr. Abrams is quite literally the world's leading expert in this topic of of teach back, which she's going to tell us about today. I don't know of any person working in this space that has thought more about it and has had a bigger impact on the use of that really critical technique. Dr. Abrams has been a co-investigator on multiple health literacy-related grants, collaborated to build capacity and infrastructure to support sustainability, and instituted an innovative health literacy curriculum at the Ohio State University College of Medicine to promote the adoption of health literacy practices amongst medical students, but in addition to develop faculty to help teach, role model, evaluate, and provide feedback on student skills. Dr. Abrams graduated from the Ohio State University College of Medicine, the Harvard School of Public Health, and the University of Dayton. Please join me in a warm OHSU and Oregon and Portland welcome for Dr. Marianne Abrams.
Thank you so much for coming up here. Yeah, thank you. All right. Wait a minute. I just do that, right? Thank you. Well, hello, good afternoon. Thank you so much for the warm welcome and for your inspirational work. Obviously, with Dr. Coleman and all these inspiring people that I've heard speak just in the last 20 minutes and yesterday, this is just really spectacular for me to learn from you as well. So thank you. I enjoyed the poster session, and I'm looking forward to the breakouts as well. So let's begin. The title, Let's Work Together to Advance as Health Literate Health Organizations to Achieve Health and Well-Being. And also thank you, Nick, for holding our hands as we get set up here, and hopefully I don't break anything as I move forward. Okay, I have no conflicts. I do want to thank my health literacy, organizational health literacy team and all of our internal and external partners and collaborators at Nationwide Children's in Columbus, Ohio, and also to let you know that some of the work that I'll be talking about was developed with some funding from the Department of Health and Human Services Office of Minority Health within the last few years. I'm going to go by these learning objectives because I'm going to speak to them as we introduce parts of my conversation. But why today's title, Advancing Health-Literate Health Organizations to Achieve Health and Well-Being? Well, Healthy People 2030's goal is to improve the health and well-being of all. And their foundational principle is that to accomplish that requires eliminating health disparities, achieving health equity, and attaining health literacy. And so I want to talk with you today about using the model, the approach of a health-literate health organization to do just that. So let's begin with some basics, some fundamentals, some foundational content. Many of you are probably familiar with this and could give this part of the talk, or all of the talk for all I know. But I want everybody to be able to describe how and why health literacy is foundational to safe, high-quality, equitable, person-centered healthcare and services. And I don't think you need convincing, but again, just some examples of why this kind of communication really matters. So this is an infant who had to be readmitted to the hospital for dehydration because their feeding tube was clogged. The parents did not remember any education or training that they had been given about how to take care of the feeding tube. A teenager with diabetes was readmitted or admitted to the hospital with hyperglycemia. Even though they'd had their diabetes education classes and learned on an orange how to inject their insulin, they'd never understood how to inject it into their own body. And finally, a very bad case, frankly, a patient who was readmitted with severe postoperative complications that required multiple return visits to the operating room because they did not understand their discharge wound care instructions. And when they did call, they were sort of labeled as being non-compliant or non-adherent, and there was never an interpreter involved in any of that communication. So all three of those, I think, are good examples of why this is such an important topic. So I'd like to begin in 2004 with the Institute of Medicine report. The first time they pulled together the body of literature that was out there to really produce a whole group of findings and recommendations. And my favorite finding is this one: health literacy is fundamental to quality care and relates to 3 of the 6 aims of quality improvement in the IOM Quality CASM report. And those include safety, patient-centered care, and equitable treatment. So this work was all predicated on that initial definition of health literacy as an individual or a personal trait, if you will. And it's the degree to which people have the ability to find, understand, and use information and services to inform health-related decisions and take action for themselves and others. And we tether our data and our current work even from the National Assessment of Adult Literacy, the NOW, which was done in 2003, yes, 2003. But what makes this so important and why we still refer to these data is because it was the first and frankly only well-done, highly representative assessment of adult literacy, but also health literacy by the Department of Education in the US. So they assessed health literacy by asking people to complete various health-related tasks. So it wasn't just word recognition, it was things like circle the time of an appointment on an appointment card, look at a pamphlet and identify 2 reasons you should be screened for an asymptomatic condition, tell us what time you would take your medicine based on the directions on the pill bottle, and look at one of those tables that people get when they're hired and have to pick their benefits and figure out how much they would need to pay for their health insurance based on the size of their family. So those are the kinds of things that were used to make these determinations. The speckled blue represents below basic, and this light blue basic. And we see that about a third, a little bit more than that, 35% of US adults fall into that below basic or basic area. And half in this solid blue are in the intermediate area. But what I find most compelling and striking is that green section. And when you see only 12% are in the proficient area, and that means the people looking at that little insurance table that we ask almost anybody who gets a new job to look at, we find that really only about 10% of US adults are proficient. So you don't have to be a doctor or a nurse or somebody with a lot of initials after your name to have proficient health literacy, but you do have to be able to understand it. And what we can take away from that is that the health system in the US communicates in a way that almost 90% of US adults struggle or do not understand. The NAL data also identified certain groups that are increased risk for limited health literacy. It doesn't mean that everybody in these groups has low health literacy, but for a variety of reasons, they're at risk for having lower or limited health literacy. So older people, people with limited education or lower income, people who don't speak English as their primary language, or recent immigrants and refugees, people with public or no health insurance, and some racial and ethnic minorities at increased risk. Okay, but haven't things gotten better since 2004? Well, that particular study has not been done, but there is the Program for the International Assessment of Adult Competencies, which has different methodologies and is actually done worldwide with different timing and different ratings and scoring. But that PIAC is the best estimate we have for more recent data. And if we look at US data from 2012 and 2017, we see that, again, about 12% of US adults are in the highest levels for literacy, and only about 9% are in the highest levels for numeracy. So it doesn't look like things have gotten a lot better. We also have decades of data that demonstrate the relationship between limited health literacy and poorer health outcomes. And they fall into many categories: less healthy behaviors like smoking and other risk-taking behaviors, less preventive care like flu vaccine or mammography screening, less personal health knowledge about, say, asthma, diabetes, their heart conditions, less ability to really make an informed choice or participate in an informed consent discussion because they have less understanding of treatment options, much more likely to have medication errors based on trouble understanding labels and the messages about their medications, increased utilization, emergency care, hospitalization, a higher risk of mortality for some conditions, and higher healthcare costs. So if you kind of pull all this together, you see that managing chronic conditions and actually some acute conditions does require health literacy skills throughout that whole process, from being able to recognize and quantify and talk about and describe your symptoms, to understand the plan for taking care of them, knowing what your medicines are, what they're for, when and how to refill them or get them filled, the difference between multiple medications, how to schedule and keep your follow-up appointments or apply for other supportive services, and when to get more help. So that's sort of the whole stream of health literacy for the individual. As we've heard so eloquently, we understand and know that health disparities contributes to limited health literacy from historical oppression, as well as ongoing discrimination and the ripple effects of that result in unequal education, economic opportunity and employment, the impact of social determinants of health, healthcare access barriers, and situations of poor communication with health providers over time in the past. And that leads to this cycle of incomplete information, confusion, negative interactions, mistrust, avoidance of the healthcare environment, and on and on. And I've heard the word trust multiple times today, and I think it's so important that this work is also about trust and all that that entails and implicates. So hopefully we have that foundation there. And now I want to talk about contributing to advancing as health-literate health organizations by applying a variety of health literacy resources and tools in both clinical and non-clinical roles and settings. So let's just take a look at this and see what we see. Okay, I don't know if I think I'll do it like this.
So Mac, you have something that we call exercise-induced asthma. That's when you get inflammation down in the lungs, causes bronchospasm, and that's why it's hard for you to breathe when you're doing exercises like swimming, gym class, that sort of thing. Luckily, we got something here that's going to fix you right up and get you back on the way. Any questions?
No.
So I'm going to send down to the pharmacy 2 things, one an inhaler, one a spacer. What you're going to do is pop off the lid here, pop it into the spacer. You're going to give yourself 2 puffs through the spacer, do it about 15 minutes before exercise, and then you should be good to go. Any questions?
No.
All right, well, that's great. So if you have any questions, you can give our office a call. Otherwise, we'll see you next year.
What did she just say? I have no idea.
So sad, but true. Maybe a little bit
So
exaggerated.
Mac, you have something
Whoops.
that we call exercise.
There we go. But I don't think it's too far off the base, and especially as perceived, say, by a patient for whom all of this is very new. If we had more time, I'd have you all shout out what you saw and observed in that. But I think many of it, we would agree that we saw lots of technical terms, medical jargon. She gave a lot of information very quickly. She asked any questions, like a yes/no question, as she was walking toward the door. And at the end of that encounter, we clearly saw that there was lack of understanding. Okay, so what? She's keeping on schedule. Dr. Curry's going to the next room, and they can move on out, right? But what follows, and why do we all come to work every day, we hope? Well, medication errors, or just not using their medicine because they're afraid they don't know how, or if they use it wrong, it could lead to a serious problem. So we blame them and calling them non-compliant, or a little bit better to say non-adherent. Poor self-management of their asthma, increased utilization if he has to come back for more to see her again, or to go to urgent care, or go to the ER, or be admitted. Dad's missing work, he's missing school, and we had this multitude of poorer health outcomes. So what can we do? I think universal health literacy precautions is a very excellent place to start. And that really means using plain language in our, not just written, but our verbal communication, and at the end of the day, to ensure understanding via teach back. So just a couple other points about health literacy universal precautions. It's predicated on the fact that clear communication helps everyone, even good readers, like quick, simple things that they can read and understand so they can move on or get more information if they want or need it. And also, anyone in this room can have limited or lower health literacy depending on the circumstances. If you're sick, or your child's sick, or you've been up all night, or you're preoccupied or on pain meds, we can all have trouble understanding and remembering. And it's more efficient, and we know that 90% of adults struggle to understand. So the bottom line is to use this universally, like we do for bloodborne pathogens, meaning use plain language and teach back, clear communication words and tools with everyone. So plain language is clear, uses just the words that we need to convey our message. It lets people focus on that message instead of the complex words. It is not baby talk, and it is certainly not dumbing down. That is a very disrespectful way of talking about plain language and how it impacts other people. And it doesn't mean that it replaces the complex technical language among the health team. And maybe they don't say that when you walk into the OR, but that does have, those words have meaning. So there's a role for those. So we're not saying that we should all dispense with that, but use these in their appropriate place. And plain language is what we need to use to communicate with our patients. But let's focus on teach back. So there's different ways to do teach back, but there are 3 essential elements. One is asking people to explain in their own words what they need to know or do in a friendly way. By having them put it in their own words, they're internalizing it, they're thinking it through, they're conveying what they understand it to mean. So it's not just repeat back or parrot it back, but can you tell me in your own words? And you want to do it in that friendly way to show that you are taking responsibility and that you're not putting someone on the spot, you're not quizzing them, it's not a test, but this is a measure of how well I explained it, what kind of a job I did. And if they aren't able to teach back, we need to remember to re-explain again, a little better, a little differently, and check again until we can make sure that we've done a good job. And so this sort of generic gold standard way of asking for teach back is, I want to be sure I explained everything well. Can you tell me in your own words what you will do so that I can be sure I was clear? There's lots of ways to use teach back and different ways to phrase it, because you don't want to just keep saying the same thing over and over. And a helpful way to say it is to ask someone what they'll tell someone else. So what will you tell your partner today about the changes we made to your blood pressure medicine during your appointment? Acknowledging up front that something is complicated or there's a lot of information involved to make it feel normal. Lots of people find these directions for preparing for your procedure confusing. To make sure I was clear, can you go over what you're going to do to get ready? And simple follow-up. Please tell me when your appointment for your next shingles vaccine dose is, as opposed to, do you know when your appointment is, or do you have your appointment? Those are yes/no questions. You want to make sure they know when it is and have that in a way they can find it and recall it. Everyone on the team, not just the doctor, not just the nurse, not just the educator, can use and should use teach back. So it can be hard to find the information you want on food labels. To be sure I explained it well, can you look at the labels in these several examples and tell me which one of these foods has the lowest amount of salt? I want to be sure I did a good job showing you how to find the lab. Can you tell me how you'll do that when you come back to get your blood checked? And let's make sure your father knows what his insurance will cover. Can you go over what he needs to look for on this list? So this is social workers, dietitians, everybody on the health team. And if you have multiple topics, you want to use this technique called chunk and check. So you may explain up front that you're going to be going through multiple topics so they kind of know, and let them know that you'll stop after each of these topics to check to make sure you were clear. Do that little mini teach back before you move on to the next topic, so that you don't just have to do this big, massive teach back at the end. If we had more time, I would walk you through a re-experiencing of the encounter we just saw, but I'll let you know that these videos are available in the Always Use Teach Back toolkit, but I'll show a little outtake of each of these. So you'll see her explaining in a good way with plain language, and also sitting down, a caring tone, slowing down, and she'll tell him that I'm going to be asking you to explain back to make sure I was clear. And also she focuses on the teen. Sometimes in peds, we're so used to talking to the parent that we've got a 17-year-old here and we're still talking to mom and dad about what they need to do. You want to make sure we focus on the right person. So then the videos also show her asking for and him struggling to teach back, her circling back and checking again, and then him able to teach back. And then she affirms his correct teach back, asks what questions do you have, and then provides a handout and shows what she's highlighted, and she points to the key information, like this is where you'll find how often to use your inhaler, and this is where you'll find another important piece of information. And the way she asks it, she says, I'm going to have you show me how to use it so we can be sure my directions were clear. She continues to be the person who's taking responsibility. So people do have concerns about, often time as well as other things, but time is often a big concern. And I've found at least 4 studies where they documented how much time it took to use TeachBack in those projects. One, it was among adults in an outpatient clinic for people with diabetes. It added about an extra 1.8 minutes to the encounter, which is not a lot. It wasn't statistically significant, but it does add up, admittedly, over time if you see a lot of patients in a day. But if you look at these other examples, in the informed consent study, they added TeachBack to that process, and it added an extra 2.6 minutes. And I would argue that an extra 2.5 minutes to make sure people understand before they give consent is totally appropriate. And then the last 2 involved using other members of the health team. One was hospitalized adults with asthma and COPD. They had hospital staff do training on how to use their inhalers. That added 4.3 minutes. And in a pediatric pulmonary outpatient clinic for asthma, it added about 7 or 8 minutes, done by respiratory therapists. And again, that's a great way of how the whole health team can and should work together to provide care. The trade-offs are thinking about how do we spend time that is inefficient or not adding value to the encounter. If you're getting interrupted, if people are calling back with questions and the nurses are answering callbacks because Mrs. Jones didn't understand what she's supposed to do, or the patients come back when they don't need to because they didn't understand what to do or they didn't understand why they should or should not return. All those things are inefficiencies, and as we explain and ensure understanding more, people are, that time trade-off dissipates. It also admittedly takes a little time to learn new skills and build them into your habits and your workflow. You've got an expert on working on building excellent communication habits. So give yourself a little grace and accept that it will take a little extra time, but as you get used to it, it will be built into your workflow. You'll learn how to explain things more clearly up front with better plain language, and it will become just part of your routine. And then, again, why we come to work, why we are in the fields we are, because we have the opportunities to improve health outcomes by using clear communication and ensuring that the care that we give gets delivered successfully. Again, some of the evidence for TeachBack, I already mentioned the study about adult patients with diabetes. When their physician used TeachBack, they had better glycemic control. The hospitalization for the adults with COPD and asthma, they had fewer acute care events within 30 days of discharge among the group that had TeachBack used. It did show a waning effect after 30 days, so they needed to, that shows that you need to continuously reinforce that at the next appointment. The asthma clinic in pediatrics, they successfully increased the use of TeachBack by the respiratory therapist and also saw a 10% decline in ED visits for asthma over the period of after they started using TeachBack. And there were not a lot of other asthma interventions being put in place at that time. They had improved patient comprehension in the informed consent discussion, and another project where they had TeachBack in a discharge bundle in a pediatric hospital had decreases in liquid medication errors and increased parent or caregiver medication knowledge when TeachBack was included. So we've talked about health literacy, how it's a product of the individual as well as the demands from our health system. So that means we have to work on improving the skills and the actions and the arrangement of the systems as to communicate, to really address health literacy, which is why we've gotten to the definition of organizational health literacy from Healthy People 2030. And I really, I get excited about this because we finally have an official definition that states that organizations must equitably enable individuals to find, understand, and use information to take care of themselves and their loved ones. So this creates sort of the expectation. It's not a law, but it's a foundation and expectation, and it grounds a lot of additional work and policy, and other work can follow from it. But together with individual health literacy, that constitutes health literacy overall. I also want to just point out, as I mentioned earlier, when I talk about health organizations and when Healthy People 20 talks about health organizations, it's not just healthcare delivery, it's also health organizations like public health, community-based organizations, pharmacies, libraries, anything that helps to promote the health of people or restore or maintain. And that health team members include clinical but also non-clinical people, and that those folks are in all of these kinds of organizations. So what does a health literate healthcare organization look like? Another group from the Institute of Medicine, a roundtable, put together the 10 attributes of a health literate healthcare organization that we could spend a lot of time on. But to kind of summarize, the first three, leadership, integrating health literacy into planning, evaluation, safety, and quality efforts, and preparing the workforce in sort of a systematic way, or sort of high-level foundational things that are needed to create a culture, to establish baseline, to be a foundation and a driver for all the other efforts that we undertake, including the end users and consumers from beginning to end, not just at the end when we roll out something new and say, don't you just love this? Making sure that we have a care environment that invites questions, welcomes questions, and makes people feel like they can and should ask questions. Attribute 6 is the verbal communication, where plain language and teach back are so important. 7 involves navigation and access. 8 is easy to read, print, and electronic materials. 9 helps guide us to look at high-risk points where you're at more risk for harm or injury, like transitions in care, medications, and consent. And then communicating costs. So I want to just really quickly give you a little share our approach to advancing Nationwide Children's Hospital as a health literate healthcare organization. And our plain language goal is that all of our patients and families will understand the information we give them to optimize their health. So in the first couple of years, we worked on kind of getting our feet under us, building some infrastructure, and decided that we wanted to focus on increasing awareness and understanding of what health literacy is, do some basic education and training, and focus again on universal precautions. We have a very robust safety and quality culture, and we use the model for improvement. So this is our key driver diagram with a goal of increasing our Enliven composite score from X to Y by the end of this calendar year. And we chose the Enliven because it maps to those 10 attributes. We set up our key drivers to include building our organizational structure, focusing on the universal precautions, building awareness, and fostering partnerships and collaboration throughout the organization with a host of those interventions that you cannot read or should not. We've developed a scorecard to track how we're doing on those interventions and some of those metrics. And then we're looking at our Enliven data by each weighted attribute over time on this x-axis, and a composite score here where they're combined with obviously the different vertical bars representing different years. And now we've started to move that into a control chart. Now we're seeing improvement. This is a very kind of loose framework, but it's a good way for us to kind of have a gauge on the progress we're making. And now that enables us to move into more exciting, deeper work, working with patient experience, where health literacy is now explicitly included in our new 5-year strategic plan that'll be rolling out in January. We are close partners with our Health Equity Office. We have health literacy-related safety event reporting, and we'll be gathering those data to look at over time. We are integrating it into our quality work, our Quality Leadership Academy, our Quality Improvement Department, so that they can help promote integrating health literacy into quality projects. Education and training beyond just one-time training and into our graduate medical education roles and some simulation work, as well as integrating it into research. Here's our Workday module and our intranet health literacy page featuring Dr. Coleman, who came to Columbus last spring and did a great job sharing his expertise with all of our teams, and it was very inspiring. We have a training series with the parallel pathways, and we'll be launching our third cohort in January. We have champions and we have teachback super users who are the kind of understand what they do by their names, promoting use of teachback, being experts themselves and coaching and bringing others along, and then promoting awareness and understanding of what health literacy and organizational health literacy are. We have in our pediatric clinic, asthma specialty clinic, where we have a project looking at documentation of using teachback for the asthma action plan. And as you can see, we're making progress there with a couple centerline shifts to promote and sustain use of teachback in those clinics. And a great example, one of the respiratory therapists who works in the asthma specialty clinic, but is also one of our teachback super users, we observed her, and she asked an 11-year-old who'd been using their inhalers for over 6 months if he had any questions, and he said no. But because she was being observed for teachback, when she asked him to tell her how he uses them, he said he takes a deep breath before using the inhaler and then blows into the spacer, which is not the right way to use your spacer. So she obviously corrected that and did another teachback, but wouldn't it have been better to have teachback used up front to assess and ensure his understanding at the outset? We're working on the shame-free environment. I think we're going to have more excitement when we have our patient experience colleagues working with us to welcome questions. And we have a very robust Department of Patient Education that does really good work with easy-to-read materials. So let's finish up by talking about approaches to support learners and colleagues in recognizing the impact of and opportunities to address health literacy in various health settings. So who's on your organization's team? What's your organization? And who are your colleagues and learners? So I understand that you have a whole lot of different people here, and so whether you're healthcare delivery or some other entity, think about public health, payers, community-based organizations, and then our colleagues and learners are clinical, providers, licensed health professions, the clinical support staff, all the people that make everything work well that are non-clinical, security, the schedulers, environmental services staff, billing, administration, attorneys, lawyers, all of those folks, administration of all kinds. And then our learners, the official learners, we're all learners, but students in all the health professions, schools, trainees, and faculty. So one resource is the Always Use Teachback Toolkit. It offers good information about Teachback and why to use it. It's publicly available at teachbacktraining.com. It has a whole section on putting Teachback into practice. One focuses on if you want to improve your own use of Teachback. One is if you want to lead or coach a team. One is for the people who get put in charge of, can you make Teachback something we all do all the time for the department or the organization? Sort of a bigger ask. So it's tailored with tailored resources. The 10 elements for using Teachback effectively in a summary form and a more detailed form are available there. There's an interactive learning module, about 15 to 20 minutes, that goes through Teachback and provides a certificate of completion and focuses on helping you get started, building a culture that supports people in taking small steps, starting with the last patient of the day, trying it one time with one patient, using that sort of PDSA approach as you improve and get better and better. Just kind of an example of how you could build your own personal PDSA. I'm going to try it with the last patient on Wednesday afternoon. And how did it go and what will I do differently? It has tools to help equip people with the common objections. What can I say when people say, oh, there's nothing we can really do, or some people just don't know, or it doesn't work, we don't have problems in our setting. Those sorts of resources are also included. And I want to comment about reliability and sustainability, because they're so important, and a lot of work goes into these sorts of things, and then a year or two later, maybe they aren't sticking. So reliability means the process, if it's teach-back or anything else, is done correctly for every patient or person every time. So you've got the process down right. People know how to do it, and they do it. And sustainability means they do it that way, and it only changes because something has changed in the right way to do a process or to carry out something. It doesn't change because everybody called in sick, or it was weekend or night, or a student nurse was taking care of a patient. You build in the infrastructure to make sure it's done right every time. And then what's this concept of making teach-back an always event? So we know what never events are. You never want to operate on the wrong side of the body. You never want to push IV potassium. Well, the counterpart to that is always events. Aspects of patient and family experiences that should always occur when people interact with healthcare professionals and the delivery system. And so that's the name of the why that we call the Always Use Teach-Back Toolkit what we call it. And it has a host of resources in its media resource library, including all the videos I showed today, lots of other resources and tools as well. Finally, just a couple points about micro-teaching. A small amount of material to a small number of learners in a brief amount of time in real time. So for those who have maybe more formal or official teaching responsibility, it's sort of like bedside teaching, but it's a strategic way to accomplish that. And by using, say, teaching scripts, having these little pearls, you can use them over and over again. You can prepare them ahead of time. You can share them, keep them in your back pocket or on your phone. You can tailor them to the clinical setting that you're working in. You can highlight important points. You can address common errors, and you can also use them to reinforce good behaviors. And then they're just-in-time teaching points. You can do it just regularly, or if there's some trigger that occurred you want to respond to. And you've got this repository of literature and evidence-based teaching points when the opportunity appears. And this is just an example of our topic-focused health literacy-related micro-teaching scripts that we use in our longitudinal groups at the College of Medicine, which I think is akin to your clinical thread, correct? And finally, these are the elements that you want to be role modeling for learners and colleagues and others. Plain language, taking responsibility, asking people to explain in their own words, and make sure you circle back if they struggle to do so. There's observation tools, and the idea at the end is to pull all these things together, use all the tools at our disposal, position descriptions, performance reviews, on top of training and education, take advantage of competencies and clinical pathways and order sets and EHR prompts and checklists, use data to give feedback and evaluate success so that you can move toward that sustainability model. Align it with your mission, and then align it with the other places that you see resonance, as you already are, and celebrate progress and success. And at the end of the day, it is about people. You want to connect to what matters to people and then move to reliability and sustainability. So I'm going to ask for 30 extra seconds for you to take a few moments to think about one step you can take when you leave, rather than just think you go out the door and everything goes on with life. But it gives you a chance to think of one small thing you can do. And then, whatever questions you have are welcome. Thank you.
We have about 10 minutes for questions. And if you would mind repeating, Mary, if you would repeat the question to the recording.
Okay.
Hi. Yes, I'm laughing. Thank you for that really fascinating, interesting talk. I was curious, can you tell me a little about the journey at your institution to become a health literate organization? It's a tremendous body of work and accomplishment, and I'm just curious of how, what were the key elements that sort of put you over the edge to be able to bring all of these disparate groups together to form that puzzle?
Yeah, thank you. I think, obviously, we have a group of people that really understand and care deeply about health literacy. And I think what it really, our approach is to seek alignment. Look, as opposed to going after the naysayers, find the early adopters, find the people whose work aligns with it. We had great rapport, if you will, with our Office of Health Equity. Interestingly, we have fabulous work, intersectional work with our dental colleagues. So that actually goes back 8-10 years. We worked on some health literacy related dental resident training. But we also have our really robust quality department. And because of that, and partly because of the role I have, I work with MOC Part 4, and I'm the GME Quality Improvement Medical Director. I get to influence the quality projects and give feedback and point that out repetitively, like, oh yeah, you want to do patient education, and that always sort of gets left to the end, right? So we're trying to elevate that. That's just as important as these other drivers and these other interventions. And then building relationships with our new Chief Quality Officer, and one of the associate safety officers who recently left. She helped us establish the safety event reporting, the health literacy related safety event reporting. So I think it's making the case, illustrating it with pictures, not getting, if you don't get the buy-in from this experience, there are others there, and then you start to build momentum. And now we're starting, like I said, we're starting to get more into, we've also been asked to join other people's projects, QI projects and initiatives, because they understand that health literacy needs to be part of this. And so they're inviting the health literacy perspective, and that gives us a whole nother group of people to talk to about it. And that's partly why we're building this health literacy training pathway, because a small but mighty group of people can only do so much, so we need to build that capacity and those additional champions for sustaining. Other questions? Oh, there's one over there. Go ahead, and then Dave.
Thanks for that wonderful talk. I think one of the things for me is one of the barriers maybe as an organization for adopting really established practices like teach-back, right, where there's really strong evidence for better outcomes, is really just a lack of awareness. And so I really appreciate you bringing this to us today and helping us raise awareness in this group. Part of that for me, I think, is that we tend to assess patients' understanding by saying things like, does that sound like a good plan? Right? Like a closed-ended question like you suggested. Does that sound, do you have any questions? Does that sound like a good plan? And I wonder how we as an organization, what advice you would have for us to help raise awareness that those kinds of assessments of understanding are really just, you know, creating, allowing us to sort of move on through our days without really actually confronting what we may or may not have achieved.
Yeah, I used to use that kind of phrase all the time. I felt like I was being really empathic. Like, does that make sense? Are we on the same page? And then getting it, because you start to realize that people don't want to admit they don't understand. They don't want to hurt your feelings. They know that you're busy. And so I think that plus building those illustrative examples where somebody said they didn't have any questions, and then they're back in the hospital. And the situations where, like the Teachback super user observation, that story is very compelling. And we observed her counterpart when we were observing her, who hadn't gone through the training, and she said, "Oh, come and observe me, I use Teachback all the time." And so we did, and she was very happy and nice and good. I don't think her use of plain language was exquisite, but then she closed with, "Do you have any questions?" And they didn't. And so she thought she was doing Teachback. She said, "I use it all the time." So people don't really understand what it is. So to me, it's illustrating with the stories, focusing on those three elements, and the taking responsibility and in their own words. Now, not every single one of those examples was used the exact wording, but we have to get the recognition that it's a different skill, and if you don't get that back, you don't know. You just don't know. If we can solve that perfectly, we'll go from 0 to 100 really quickly. Hope that helps. Thanks.
Thank you. Let's get a good level of volume here. So I have a number of questions. I came today without any knowledge of these presentations, and you have certainly given me plenty to be thinking about. One of the first questions I would have, and I'll be quick, is how do you bake this type of performance and your metrics and your scorecard into the annual compensation plan for the people that will actually be using it?
One thing that we were pleasantly surprised about was when we recruited people for the training series, the Health Literacy Champions and the Teachback Super Users. The supervisors of those people and the managers were excited to include that work as part to contribute to their merit. So they brought that up, and they're using that. So we're hoping to expand that more broadly so that people see that as a motivator, and that people see that. We had a call with the managers and supervisors, and we were like, oh gosh, are they gonna let these people come to some meetings and trainings and blah, blah, blah. And they were like, oh, we've got this part of our, development for our nurses or whatever, and this would help us meet that goal and improve use of Teachback at the same time. So that's one approach. Once we've got more than a year's worth of data, but there was a changeover in the system, so the first year or so kind of got lost. But I think once we get a year's worth of data, and we'll be able to really describe our health literacy related events and errors and quantify them and categorize them and show the variety. We've had several that required increased monitoring to make sure they're okay. And I think that will help drive it as one of our higher level quality indicators. We'd like it to teach back to be included as one of our, we call them zero hero tools, to have zero harm, and that would be a goal as well. So kind of using these data that we're generating as they mature, and then we're really working with our new CQO, our Chief Quality Officer, hoping that she'll be pulling that in as well. She's, going to be thinking herself about how this is going to go, so we're hoping to be able to influence that as well.
Thank you. The last thing, and I can follow up with an email later, is let's say when I leave here today, I want to give my executive director of the clinic some understanding of this and say, I'd like to see this done. Do you have a package that helps me do that?
I would suggest the Always Use Teach Back Toolkit. There's some resources in there for talking to leadership and engaging leaders. There's, take a look at that section on improving Teach Back in my organization. It's got things like how to do it, but it also has the documentation, if you will, to make the case.
So
And-
just before I hand the mic back.
I'm sorry?
Before I hand the mic back.
Oh, okay.
Can you help me be more literate in finding that again so I don't go sideways?
It actually has an easy thing. It's just that's the longer thing. Teachbacktraining.org. I don't know if you can read that at the bottom, I realize that. Teachbacktraining.org, and I think someone pointed out that there's a handout in the packet, and the URL should be on the bottom.
All right. Thank you so much. What a wonderful
Okay.
speech. We have a 15-minute break, and then we're going to go to breakout sessions. So